training, I did an additional year of general surgery in Manhattan. I did a year of orthopedics at New York Medical College, and then another 3 years of orthopedic training up at SUNY Health Science Center in Syracuse. After getting my orthopedic training out of the way, I proceeded with further training for 2 years, which encompassed training in shoulder, hand, and upper extremity surgery at the University of Gainesville in Florida. And then I did an additional year of spine training at the North Carolina Spine Center in Chapel Hill, under Dr. Stephen Grubb and Paul Suh. Here at the Carolina Spine and Hand Center, we see a number of patients dealing with hand, upper extremity, and spine surgery from not just Salisbury and Rowan County, but from surrounding areas. I actually have a number of patients that come down from up around the Surrey area, Mount Airy, Southern Virginia, and also as far east as Raleigh-Durham, Cary area, and also from south of here, from Charlotte, Mooresville, and Statesville. I do a number of procedures that are not typically done by a lot of the surrounding physicians, including endoscopic carpal tunnel releases and minimally invasive spine procedures. We're a little bit unique here in that I not only do orthopedic procedure, I also do some interventional pain management procedures and surgical pain management procedures to try and help not just diagnose patients' pain pathologies, but also try and minimally treat their pain pathologies as well. We're a little bit different from an orthopedic standpoint and spine standpoint here at Carolina Spine and Hand, in that I don't just do operative interventions for spine surgery. I also do interventional diagnostic procedures such as transfemoral blocks, medial branch blocks. I do rhizotomy procedures, either open or endoscopically, and I also do what I call surgical pain management, where through minimal incisions, either through a scope or through a small tube, I'm actually able to do procedures that others would do using open techniques, or certain techniques that other physicians around this area don't even do. Here at Carolina Spine and Hand Center, we try and take a team approach. I also have a physician assistant that helps me see patients and work up and diagnose patients' pathology, from everything from shoulder, elbow, hand, and also spine pathology. Helps facilitate getting patients in to see me, and it also helps with the flow within the practice itself. What I like to try and do for my patients, even though I am an orthopedic spine specialist and upper extremity specialist, is I like to try and take you down a conservative route myself if I can. So within my practice, I've tried to develop diagnostic procedures to help facilitate treatment of patients and coming up with a better avenue of non-operative care. We have within this practice physical therapy. I have a physical therapist by the name of Andy Elton who can help me out from a physical therapy standpoint. I do minimally invasive diagnostic procedures here, such as a lot of the pain management physicians do, where we do transfemoral blocks, medial branch blocks, facet injections, sacroiliac joint injections, and midline epidural blocks to try and determine where exactly somebody's pain is coming from. Once we know where somebody's pain is coming from, we can actually treat them with just the injections themselves until they don't work anymore, or we can actually move on to less invasive surgical interventional procedures. I like to say surgical interventional pain management rather than interventional pain management, because it's a little bit more invasive, but it's not to the invasiveness of a standard open surgery. In talking about those type of procedures, what I mean are, instead of doing procedures where we ablate or burn the nerve in the office to help with back pain, I can actually do them surgically through 7-8 millimeter incisions and be able to take care of people's pain longer than what I can do with an interventional procedure. I can also do discectomies in patients that no longer are getting relief from transfemoral blocks, or do a combination of facet procedure with disc procedure for people that have back and leg symptoms instead of just one or the other. So here in this practice, I kind of got a nice spectrum of procedures that I can do and interventions that I can do before taking somebody down a more maximally invasive route.